The reason we need new therapies for patients with Philadelphia positive acute lymphoblastic leukemia is because we still have many patients, unfortunately, that do not have the outcomes that we want. The treatment has evolved dramatically from the days where we used only chemotherapy. Then with the introduction of tyrosine kinase inhibitors, the prognosis has greatly improved. Nowadays, with a combination of some sort of chemotherapy and a tyrosine kinase inhibitor, we think that probably about 60–65% of the patients can be alive long-term. But number one, there's still a good 1/3 of patients who don't have that positive outcome. Number two, some of these treatments are not free of risks. The chemotherapy itself, of course, has risks. And some of the tyrosine kinase inhibitors that we use have some potential side effects, and we're learning how to use them better and to minimize risks, but still those risks exist. And then when patients relapse, we do not have as great of an outcome as we would expect, as we would like to have for those patients who eventually lose their response, and definitely for those who do not achieve a response. So for all of these reasons, we still need to find better treatment options for patients with Philadelphia positive acute lymphoblastic leukemia so that we can get to a higher cure rate and the one that is achieved with less toxicity, with better quality of life, and also hopefully without the need of stem cell transplant. We've been able to do that more and more nowadays, but we still need transplant in some patients, and not that transplant is anything bad, but of course by itself has its own complications and also limitations, finding donors, etc. So we still have a way to go. As much as we have advanced, there is room for better treatments, better tyrosine kinase inhibitors, probably other options and monoclonal antibodies, etc., that can help us get to these better outcomes. What this means to patients is that, well, the most important thing is that the outcome is much better nowadays. It used to be that if you had Philadelphia positive acute lymphoblastic leukemia, your probability of surviving even a year was minimal. If you could not get a transplant, it certainly was almost non-existent. And even with transplant, the outcomes were not good, not as good, certainly, as if you did not have the Philadelphia chromosome positive and acute lymphoblastic leukemia. Nowadays, those outcomes, the probability of being cured has improved dramatically. And this is very, very important. And even for patients who cannot get to a transplant, patients who are not candidates for a transplant, who do not have a donor, etc. Now, we still need to get better treatment. So that means that still enrolling in clinical trials, participating in new studies that help us to get to those improved outcomes is very important. But I think the main message has to be that a patient today that has Philadelphia positive acute lymphoblastic leukemia can be cured, and can be cured even without a stem cell transplant. And we also have the fortune of having better ways to measure residual disease after achieving a remission, and that helps us also determine who is better served by going to a transplant and who can be doing well with only the treatment with chemotherapy plus a tyrosine kinase inhibitor. So I think the prospects for a patient today are incredibly better than they were just 10–15 years ago, and probably even more recently.